Good day to whoever is watching this video. This video will tackle one of the emergencies in the field of ophthalmology, trauma to the human eye, in the context of acute corneal abrasion. But before we delve further in discussing corneal abrasion, let's first have a brief review of eye anatomy. The cornea is a transparent dome-shaped window that covers the front of the eye. It covers the pupil, iris, and the anterior chamber. The cornea's main function is to refract or bend light. It is also responsible for focusing most of the light that enters the eye. The cornea has several layers of cells and membranes. The thin top layer, called the epithelium, is composed of sensitive cells that are similar to skin. Below this surface layer lies a tough protective structure called Bowman's layer. The epithelium and Bowman's layer together make up only 10% of the thickness of the cornea. But these two layers are most involved in corneal abrasions. The image to your right shows a healthy cornea, while the image to your left shows a corneal abrasion. Corneal abrasions are one of the most common forms of eye injury. In some cases, they are caused by the direct impact of a sharp object. It can also be caused by a simple nick from your fingernail when you're rubbing your eyes. Patients with acute corneal abrasion usually come in complaining of sharp pain in the affected eye. As you can imagine, it causes grave discomfort, warranting it as an emergency. Other symptoms are as follows: tearing and discomfort when blinking, and the feeling of having something in your eye. Patients can also present with photophobia, meaning pain when light enters the eye. They can also come in with a swollen eyelid and share a history of scratching or hitting their eye. The next step would be for the physician to examine the patient's eye with a light to check for any obvious corneal injuries, small specks of dust or dirt, or other foreign objects. To confirm the diagnosis, a physician may need to place a small drop of a yellow-orange dye called fluorescein into the patient's eye. This dye will cause any area of abrasion to look green under a special blue light. If the injury is more serious, a physician may examine the patient's eye with a device called a slit lamp and also test the patient's vision. A physician uses a slit lamp to evaluate for an anterior chamber reaction. Although this is a post-op image of a lens insertion, it shows an anterior chamber reaction with whitish deposits on the anterior surface of the lens. This is similar to what we would see in a flare or anterior chamber reaction in the event of a corneal abrasion with penetrating trauma. During the physical examination, it is also crucial to check for foreign bodies. As the image illustrates, a doctor can make use of a cotton pledget and twist it upward while asking the patient to look downward in order to evert the eyelid and check for foreign bodies. Now, let's talk about the treatment for acute corneal abrasion. Doctors usually prescribe antibiotic ointments or drops. For patients who don't wear contact lens, they can be given bacitracin with polymyxin B to be applied every 2 to 4 hours, or antibiotic drops like polymyxin B with trimethoprim, or a fluoroquinolone like ciprofloxacin or moxifloxacin. Abrasions caused by nicks from a fingernail should always be covered with a fluoroquinolone. For patients who wear contact lens, they may use the same antibiotic ointment or drops 4 times a day, but they should be given anti-pseudomonal coverage in the form of gentamicin sulfate. Ointments offer a better barrier and lubricating function between the eyelid and the abrasion, but tend to blur vision temporarily. Some doctors would advise patients to use drops during the day and ointments during the night, but this would still depend on the patient's convenience. This brand is available locally. Physicians can also give a cycloplegic agent like 1% to 2% cyclopentolate for traumatic iritis, which may develop 1 to 3 days after trauma. They can also give topical nonsteroidal anti-inflammatory drug drops like ketorolac for pain control. It is also important to debride loose or hanging epithelium because it might hinder healing. With the use of a cotton-tip applicator soaked in topical anesthetic or a sterile jeweler's forceps. For patients who wear contact lens, they should be advised not to do so for the time being. That will be all for acute corneal abrasion. With the proper treatment, patients usually have a good prognosis. This video was made as a requirement for my clinical rotation in ophthalmology and should only be used for educational purposes. Thank you for watching. Stay safe in the comforts of your home and have a wonderful summer.